Sometimes the universe asks me to make a video, and so when it does, I listen. And what's happened in the last couple of weeks is I've had various people say, I've been looking on your YouTube channel for a video on diverticulitis because I'm dealing with it right now, and you don't have anything. And I'd love to have information beside what's on the Mayo Clinic website or on, the mainstream Google website. So for those people, and all future people looking, here's a video for you. So today we want to look at research first to understand what is diverticulitis, what contributes to it, what are mainstream treatments, and then what are options for us naturally that we can implement to eliminate the pain and inflammation of diverticulitis and move on with our life. And so we're going to dive into the research on that today, and hopefully it's beneficial for you. So let's dive in. The first paper we'll look at is from Current Problems in Surgery from 2020, entitled Diverticulitis, an update from the age-old paradigm. And I like this paper. You can see over here, it's 95 pages long. We're not going to read it all today, but if you are really interested in diverticulitis, this is a great one to read. We're just going to pull out some history on diverticulitis so we can all start from a baseline and move on from there. So here you can see, for a disease that affects so many, we continue to struggle to define optimal care for patients with diverticular disease. So this is a journal. Surgery is one common treatment for diverticulitis. So this surgical journal is admitting, hey, we are the surgeons. We're the people who are doing this all the time. And even we say that we struggle to define optimal care for these patients. Diverticular disease was rarely described in the literature prior to the 1900s. So it's relatively new, right? It's only 70 years old if we go by what this paper is citing, where they say in the late 1960s and early 70s, two authors popularized the theory that diverticulosis is a disease of Western civilization based on the observation that diverticulosis was rare in rural Africa, but common in economically developed countries. So the theory is that it's a disease of Western civilization, a disease of affluence. And so if we say, what is the difference between Western civilization and African countries? It's the wealth, and it's how drastically we've changed our lifestyle in every way compared to hunter-gatherer ancestors, right? We're more sedentary, we sleep less, we're more stressed, we get less sun exposure. Our diets are wildly changed from the, hunter-gatherer paleo type diets to refined sugar, white sugar, processed foods, processed drinks, etc. So those are areas that if you're looking at a disease and we're seeing, hey, it never existed in the literature before the 1900s, and it tends to be in Western affluent societies, then we look at, well, what's different between those societies? And those can be the nodes that we can intervene on and say, okay, how do we return our lifestyle to that of an African or hunter-gatherer type lifestyle? And do we see reduction in diverticulosis and diverticulitis? Now, just for those who are out there thinking, well, what's the difference between diverticulosis and diverticulitis? Diverticulosis, you could think of as you have diverticuli, which are little out pouches that grow in the colon. So if we draw a colon here, say this is the colon and this is where food and water move through. This is the inside of the colon of the GI tract. If we're looking down the tube and we cut it in half, now we're looking at it this way, right? And so here's one wall and here's the other wall. So diverticuli occur when we see outpouches happen or outpouches form. So you get these little pockets in the colon, okay? And those are diverticuli. Now, you can have diverticulosis, which is, say, chronic diverticuli that aren't really aren't active from an inflammation standpoint currently, Diverticulitis, the last four letters itis means inflammation. Diverticulitis is current inflammation in there for whatever reason. We'll just go through many reasons on today's video. So if you have inflamed pouches in that colon, that's diverticulitis. And that is when you're symptomatic and seeking out help at the ER or at your medical doctor's office. So moving on with our history lesson. The role of diet in preventing diverticular disease has long been debated. A high fiber diet appears to decrease the likelihood of symptomatic diverticulitis. The myth of avoiding eating nuts, corn, popcorn, and seeds to prevent episodes of diverticulitis has been debunked with modern data. So you used to hear, okay, if you have diverticulitis, like in school, they taught us, have your patients avoid nuts, seeds, popcorn, small things that can get stuck in those diverticula. But as we've talked about before, cutting edge research takes about 17 years to make it into the textbooks and into the classroom. So I was taught old data. Modern data says those things aren't a factor. Overall, the recommendations for quote unquote diverticulitis diets mirror those made for overall healthy lifestyle. And so you'll notice I stopped highlighting there because then they say diets for healthy lifestyle are high fiber with a focus on whole grains, fruits, and vegetables. Well, the focus on the whole grain sounds like a food pyramid thing, and we know that's not healthy. That's what Western societies do, and Western societies are the ones with diverticulitis, right? So we want to have a healthy diet that's more in line with our hunter-gatherer ancestors. So, a paleo or ketogenic or more carnivore-ish type of diet. Diverticulosis is one of the most common incidental findings on colonoscopy. It's the eighth most common outpatient diagnosis in the United States. So that's very common. Over 50% of people over the age of 60 and over 60% of people over the age of 80 have colonic diverticula. So diverticuli in their colon, large intestine. Of those with diverticulosis, the lifetime risk of developing diverticulitis, the acute inflammatory form, is estimated at 10 to 25%. Diverticulitis accounts for an estimated 371,000 emergency department visits and 200,000 inpatient admissions per year for an annual cost of up to $2.6 billion in the US. So it's a big deal. It's expensive. The incidence of diverticulitis is increasing. All right, so it's becoming more and more common. So is that genetic? No, our genes aren't changing. So it's something in our lifestyle and our environment that is driving the increased incidence. Besides increasing age, other risk factors for diverticular disease. Listen to these because these are very common. NSAID medications. So NSAID is non-steroidal anti-inflammatory drugs. Aspirin, steroids, opioids, smoking, and sedentary lifestyle. So look at that. Medications make up almost that whole list. So medications are a significant driver for diverticular disease. Smoking is a big one. And then sedentary lifestyle. So not moving, not exercising. So we want to be moving. Movement is life. And one way that it helps you specifically is by helping prevent diverticulosis and diverticulitis. The most common presenting complaint in diverticular disease is left lower quadrant abdominal pain with symptoms of systemic unwellness like fever and malaise. Malaise is kind of like just blah feeling. However, the presentation may vary widely. The gold standard imaging is multi-detector CT scan. It is minimally invasive and has a sensitivity between 98% and specificity up to 99% for diagnosing acute diverticulitis. Uncomplicated acute diverticulitis may be safely managed as an outpatient in carefully selected patients. Hospitalization is usually necessary for patients with immune suppression, intolerance to oral intake, signs of severe sepsis, lack of social support, and increased comorbidities. The role of antibiotics has been questioned in a number of randomized controlled trials, and it is likely that we will see more patients with uncomplicated disease treated with observation or kind of wait and see in the future. Now, this is interesting because I started the video by saying two people in the last couple of weeks have asked me to please make a video. Well, both people, one has had persistent diverticulitis over the last year or so with multiple flares, and she's been treated with antibiotics multiple times. The second person had an acute diverticular attack for the first time last week, went to the ER and was given antibiotics. So both were treated in a way that is not up on the research or not supported by the research anymore. So again, it takes time for the research to make it into the clinic, but just interesting to see both of them may have been put on an antibiotic that was unnecessary when hopefully soon future treatment for acute uncomplicated cases will be, well, let's just wait and see. Okay, and we'll see why we may not want to take antibiotics here in a moment. In addition to, probably the multiple reasons you already know. So that is all we'll take from that 95-page paper. But again, you can download this and read it for free if you like. The next paper, this one, the first was from 2020. Here's one from 2022, Updates in the Understanding and Management of Diverticular Disease. This is from Current Opinions in Gastroenterology. So again, from the expert journals of the people who treat this day in and day out. And their paper says, diverticulosis leads to significant disability and death and is increasing in the prevalence worldwide. Recent literature suggests that antibiotics are likely not necessary for low-risk patients with acute uncomplicated diverticulitis, and not all patients with recurrent diverticulitis require colectomy. Okay, so treatment for the acute case, like we just talked about, is often antibiotics. Treatment for recurrent diverticulitis is often colectomy or the surgery. They'll take out part of your colon. Well, the first person who asked me to make a video who's had the recurrent flares, that's what they told her is, we're going to schedule you for a surgical consult. And she's saying, I don't want to have part of my colon taken out. So she reached out to me to see, is there anything naturally that can be done? And so when your options are only drugs and surgery, which they often are in the mainstream model, you have to look outside. Interestingly, this paper says dietary restrictions do not prevent recurrent diverticulitis. I would argue that point, but this is their opinion in their journal. Visceral hypersensitivity. So visceral is your organs. Hypersensitivity is, hypersensitive, right? So visceral hypersensitivity is increasingly being recognized as a cause of persistent abdominal pain after acute diverticulitis and should be considered along with chronic smoldering diverticulitis, segmental colitis associated with diverticula, and symptomatic uncomplicated diverticular disease. So basically, if they're saying, hey, diet doesn't help prevent it, we need to consider visceral hypersensitivity. So basically, the nerve endings in your gut are way too sensitive, and that's triggering the pain. Well, diet can trigger nerve endings. One component of the diet that is very well known to trigger the gut nerve endings and drive pain is histamine. So if someone's eating a high histamine diet, that could plausibly drive the pain and diverticulitis. And some of those foods may also drive inflammation in the diverticula themselves. So I would argue that diet does matter, and I think most people, just thinking, common sense wise, would agree. Summary: clinicians should be aware that traditionally held assumptions regarding the prevention and management of diverticular disorders have recently been called into question, and they should adjust their clinical practice accordingly. So again, not giving antibiotics immediately just because you discover an uncomplicated case, and perhaps with recurrent cases, not jumping to surgery if things like diet and other factors we're about to cover are out of whack in the patient. So, if it's not seeds, if it's not avoiding nuts, seeds, and corn, what can we do, or what might be contributing to diverticuli forming in people's colon at such an alarming rate? Well, one is body weight. Here's a study from Gastroenterology, again, the Gut Specialist Journal from 2018. And this paper looked at the association between obesity and weight change and the risk of diverticulitis in women. The makeup of the study: It's a prospective cohort study of over 46,000 women that were enrolled in the Nurses' Health Study between the ages 61 and 89. And none of these women, none of those 46,000 women at the start of the study had diverticulitis, diverticular bleeding, cancer, or inflammatory bowel disease. So for the purposes of this study, none of them had any issues in their GI tract related to diverticular disease. What they wanted to do is follow these women for 6 years and determine, was there an association between the risk of first-time diverticulitis and increasing body mass index, waist circumference, waist to hip ratio, and weight change from 18 years old to present. Right? So essentially they're looking at how does weight gain and the associated body changes contribute to diverticulitis, if at all. So for 6 years, they followed these women and they said, we documented 1,084 incident cases of diverticulitis over 6 years. Out of 46,000 women, 1,084 developed it. After adjustment for other risk factors, women with a BMI greater than or equal to 35 had a 42% higher risk of developing diverticulitis compared to women with a BMI less than 22.5. BMI is body mass index. Compared to women in the lowest quintile, women in the highest quintile were 35% more likely for waist circumference and 40% more likely for higher waist to hip ratio to develop diverticulitis than women in the lowest quintile. Compared to women maintaining weight from their 18-year-old weight to present, those who gained 40 pounds or more had a 73% increased risk of diverticulitis. So in conclusion, over their 6-year follow-up period, these authors observed an association between obesity and risk of diverticulitis in women. Weight gain during adulthood was associated with increased risk. So again, we all control that, right? If you still fit into your prom dress, you probably don't have increased risk of diverticulitis. If you laugh when someone asks you, would you fit into your prom dress today? Then you may have up to 73% increased risk of diverticulitis. So weight gain as adults, and this probably is true for men as well, is a significant associated factor for diverticulitis risk, and we want to control that. Well, how do we do that? Physical activity is one way, and as we saw in the earlier study, a sedentary lifestyle is one risk factor for diverticulitis. So staying active and exercising is going to help prevent your diverticulitis from occurring by keeping your weight down. Nutrition. You know, the experts say diet doesn't matter. Well, yeah, it does. If you're telling us weight gain matters, then diet matters, because a significant way people gain weight is by eating poor diets. And diet, you know, drastic dietary change is a major obvious observable factor between Western societies and African countries. So diet absolutely is going to play a role. And so we want to keep our weight at good levels, and that's what this is saying too. All right, next factor. What about the gut? This is the most recent study we'll look at today, and this is from 2024 in Nature. Gut microbiome composition and metabolic activity in women with diverticulitis. These authors, again, admit the cause of diverticulitis among the most common GI disease diagnosis remains largely unknown. So they're trying to figure out, can we identify causes for diverticulitis? They're looking at the gut. What they did was they took stool samples within a large prospective cohort, and they profiled, they studied those stools. So they took stools from 121 women that were diagnosed with diverticulitis and required antibiotics or hospitalization, and they matched those stools with stools from 121 women without diverticulitis. They were control women, they were healthy, and they were matched for age and race. Overall, they found that the microbial community and metabolomic profiles, so basically different metabolites and inflammatory markers, differed in the diverticulitis women compared to the women without it. The women with diverticulitis had enrichment of pro-inflammatory bacteria and metabolite, like 1,7-dimethyl uric acid and histidine-related metabolites. Histidine gets converted to histamine by many bacteria through an enzyme called histidine decarboxylase. So again, remember with the visceral hypersensitivity, the previous study was talking about visceral hypersensitivity drives the pain in diverticulitis, while histamine will trigger those gut nerve endings to drive pain. So this is important. The women with diverticulitis also had depletion of butyrate producing bacteria and anti-inflammatory ceramides. Well, what is butyrate? Butyrate is a short chain fatty acid that is made by bacteria, good bacteria, that nourishes your colon, and it's very anti-inflammatory. So if you've got a microbiome that is swung towards depletion of those butyrate producing bacteria, you're lacking that anti-inflammatory stimulus, you're lacking that colon nourishing short chain fatty acid production, and so your colon is more unhealthy and you're more prone to develop diverticula and inflammation in them. The authors also state, we observed that microbial composition modulated the protective association between a prudent fiber-rich diet and diverticulitis. So here's a deeper look, right? A common recommendation if you have diverticulitis and the woman who's had repeated flares over the last year that I spoke about earlier, she's been told eat more fiber. And so has the woman who had the acute flare here recently. So that's a common recommendation they make. Eat more fiber, eat more fiber. Well, one reason fiber could help these people is because our good microbiota, the probiotics, the good bacteria, they eat that fiber. So fiber is a prebiotic or the food that our probiotics eat. And so if we can feed the good bacteria with more fiber, they'll make more butyrate for us, which will be more nourishment to our colon and more anti-inflammatory and help reduce the diverticulitis inflammation or prevent it from happening in the first place. So that's the connection from the fibers, what the bacteria are going to do with it to help our guts. The authors conclude, our findings offer insights into the perturbations and inflammation-related microbial metabolic signatures associated with diverticulitis, supporting the potential of microbial-based diagnostics and therapeutic targets. What does that mean? So their findings say, hey, microbial-based diagnostics, which would be, hey, stool tests and measuring bacterial loads, virus, worms, yeast, parasites, all the things we want to measure in the gut, and therapeutic targets. So, hey, addressing the microbiome is a therapeutic target for us. So, if we're not going to avoid corn, nuts, and seeds, well, then what can we do? One thing you can do is control your weight, eat a good diet, stay active. Well, here's another one. We can promote a healthy gut microbiome through nutrition, sleep, diet, stress, fiber, and many other ways. What else matters? Stool frequency. So this is from the journal Clinical Gastroenterology and Hepatology. So again, the gut guys. Gastroenterology is gut, as we've been talking about it. Hepatology is liver, right? So again, the gut specialists. This is from 2022, and they're looking at the frequency of bowel movements and risk for diverticulitis. So historically, constipation has been thought to be a driver of diverticulitis. So these authors, again, took participants from the Nurses' Health Study, and they drew participants from a different study called the Health Professional Follow-Up Study. So in the Nurses' Health Study, they had a 24-year follow-up where they documented over 5,200 new cases of diverticulitis in the nurses. In the Health Professional Follow-Up Study, they followed them for 14 years and documented 390 new cases in that study. And what they observed was an inverse association between the frequency of bowel movements and risk of diverticulitis. The association between bowel movements and diverticulitis was not modified by categories of age, BMI, physical activity, laxative use, or fiber intake. So what that says is, hey, how frequent your stools are mattered regardless of how much you weighed, how active you were, how much fiber you ate. And surprisingly, the more frequent bowel movements are a greater risk factor for diverticulitis in men and women than less frequent. So diarrhea was a greater risk factor than constipation. That's interesting because, again, historically, constipation was thought to be a driver. Well, why? How do we explain that diarrhea is a driver and are more of a driver than constipation? I'm glad you asked. The authors lay out a couple explanations here. Although our findings challenge traditional assumptions associating constipation with diverticulitis, they have biological plausibility. First, considering body position and how it influences defecation or stools. It may be that the traditional Western method of defecation while seated on a toilet may influence diverticular formation, which is a necessary factor for susceptibility to diverticulitis. So basically, our toilets and the way we sit on them may be driving diverticulitis risk. In a study in which participants were tested for defecation in 3 positions: sitting with hip flexed at 60 degrees with respect to the rest of the body, and squatting with the hip flexed at 22.5 degrees, the author found that squatting resulted in a straighter anorectal canal compared to sitting, and thus less strain during defecation. Another study found that the thinker position while defecating resulted in a wider anorectal canal and thus potentially less colonic strain during defecation. In support of this theory, sitting during defecation on Western-type toilets can be an independent risk factor for diverticulosis. So again, we saw at the start, the first paper said diverticulitis more common in Western societies than African societies. And we said, hey, diet's probably one obvious difference. Well, so is physical activity. Well, so is how we poop, right? We're sitting on nice toilets with indoor plumbing. Hunter-gatherer peoples are squatting in the woods, right? And that squatting position is what humans have been doing throughout time until indoor plumbing. And so our colons are used to that. And so this is likely another contributing factor. And it's likely a driver to all the money the squatty potties have made. If you watch Shark Tank, the squatty potty was one of the big winners there. And all it is a little stool you put in front of your toilet and you put your feet on, which changes your hip angle, like they're talking about up higher, to make it like you're squatting, and it helps your stool come out more easily. So if you have diverticulitis, one strategy would be buy a squatty potty, since you're probably not going to dig a hole in the ground and squat. Since sitting is the most common position for defecating in Western cultures, while squatting is more common elsewhere, these data may explain, at least partially, the ecological findings of higher rates of diverticulitis in Western societies. If the sitting position results in higher colonic strain, then more frequent bowel movements may plausibly result in higher risk of diverticular disease and/or diverticulitis. Second, it may be that more frequent bowel movements influence gut microbiota composition, which may play a role in the risk for diverticulitis. Recent studies suggest that both stool consistency and bowel movement frequency are factors that modify the gut microbiome. So we just said in this previous study, the gut microbiota are different in the diverticulitis patients compared to the normal patients. And it'd be interesting if they let us know, well, what was stool frequency like between those groups as well. This paper suggests that if the stool frequency was different and was higher in the diverticulitis group, that may be one reason why the microbiome was different in that group as well. An increasing body of evidence suggests that patients with diverticular disease harbor distinct gut microbiota composition and that its alteration is implicated in the pathogenesis of the disease. Well, yes, we just saw that in a more recent study right here, right? Diverticulitis patients have different gut bugs than non-diverticulitis patients. Indeed, the association between diet, physical activity, and obesity with diverticulitis may, at least in part, be mediated by alterations in the gut microbiota. Yes, and we've talked about this in the past. You might remember the bacterium Akkermansia mucinophilia. We've made videos on this in the past. That's the darling of probiotic research right now because it's associated with optimal insulin sensitivity, optimal cholesterol metabolism, optimal body composition, optimal gut barrier integrity. So, the body composition, the gut barrier integrity would play direct influences on diverticulitis risk based on the evidence we've looked at today. A third related possibility is to postulate the presence of chronic low-grade inflammation similar to what may be present in irritable bowel disease or irritable bowel syndrome, IBS. Interestingly, most data on the existence of low-grade inflammation in IBS comes from patients with diarrhea. The existence of chronic low-grade inflammation may predispose to more frequent bowel movements as well in diverticulitis. These three mechanisms are not mutually exclusive and may play a role in the onset of diverticulitis, a multifactorial disease. So what that says is it's possible you have all three of these things going on and other factors. So again, to wrap it up, rather than have a diverticulitis diagnosis and just jump on an antibiotic, which by definition will drive imbalance in your gut microbiome and potentially make your diverticulitis worse or recurrent, or jumping into colon surgery, why don't we step back and observe, have I suffered from any of these factors we've covered today? Have I gained weight, especially significant amounts of weight, 20 to 40 pounds since I was 18? That's something I could work on. And if I have, then how has my nutritional lifestyle choices, my physical activity lifestyle choices, my stress and my sleep influenced that weight gain? Am I having frequent stools? Do I have frequent loose stools? And the study looked at one stool a day as being normal and greater than one stool being more frequent and increased risk, with less than one stool obviously being on the constipation side of things. And so stool frequency and quality are going to matter. And again, if you're having chronic diarrhea, you may have chronic low-grade inflammation similar to what IBS patients have. We saw nutrition can matter. If you're having visceral hypersensitivity, perhaps that hypersensitivity or the hypersensitivity to pain is being driven by histamine, and histamine from the diet is a very common source of high histamine levels in the GI. Imbalanced microbiome or imbalanced bacteria, especially if you have lots of bacteria that produce histidine decarboxylase, those bacteria may be driving histamine production or conversion at too high a level and driving your pain. If you're lacking the good guys, you may be missing butyrate, and butyrate is colon nourishing and anti-inflammatory. And if you're eating good fiber but you don't have the right bugs, then they're not producing enough of that butyrate to nourish your colon. So there's lots of actions here. Do you have a squatty potty? Are you squatting it or pooping at the right angles? If you have a normal toilet, then no. So purchasing a squatty potty could help you, or creating your own stool, or putting your feet up on something when you go could help improve that anorectal pathway there for you. So I hope this video was informative. I hope it gave you ideas for you to look at your own life and assess where could you clean it up and potentially help yourself with your diverticulitis without having to move forward with antibiotics and or surgery. So thank you for watching. Let's open it up.
What are good sources of fiber that aren't fruit?
Well, vegetables, root vegetables are good. All your vegetables, green leafies, root vegetables, your tubers, your sweet potatoes and taro and squashes. And then if you're looking at fibers to purchase a supplement type, psyllium husk is good. Apple pectin is good. Partially hydrolyzed guar gum is one that's been highly researched in both constipation and diarrhea. That's sold under the brand name Sun Fiber. So lots of options there.